All right, today we're going to tackle sporotrichosis. It's this really fascinating fungal infection. And in this explainer, we're going to cover pretty much everything you need to know about it, from the fungus itself all the way to how we diagnose and treat it. So let's start with a quick question for you. What disease gets the nickname Rose Gardener's disease? If you know this one, you're already on the right track. That nickname is a huge clue about how this whole thing gets started, and it's something we'll circle back to a few times.
All right, so here's our game plan. We'll start with the basics. What is this thing? Then we'll get into the fungus, what it looks like in a patient, how we diagnose it, how to treat it, and we'll finish up with some must-know pearls for your exams.
Okay, section 1. So, what is sporotrichosis, really? Let's get a solid definition down and figure out who's most at risk.
Okay, so at its heart, sporotrichosis is a chronic fungal infection. It usually hangs out in the skin and the tissues right underneath, the subcutaneous layer. The culprit? It's a fungus from what we call the Sporothrix Schenckii complex. And here's a key word you got to remember, dimorphic. All that means is that this fungus can exist in two different forms. We're going to get into exactly what that means in just a bit. So, who's at risk for this? Well, that nickname Rose Gardener's disease really tells you a lot, doesn't it? It's basically an occupational hazard for anyone who gets their hands dirty. Think gardeners, farmers, forestry workers, those are the classic groups. But also veterinarians and even cat owners. Basically, if you're handling soil, plant debris, sphagnum moss, you're in the potential exposure zone. The common denominator here is getting poked or scratched by something from the environment.
And that brings up a really important point. It's not just about plants. Sporotrichosis can be zoonotic. That's just a fancy way of saying it can jump from animals to people. And guess who the major culprits are? Infected cats. They can spread it through a scratch or a bite. It's a perfect example of how the health of the environment, animals, and humans are all tangled together.
All right, let's zoom in a bit. In this next section, we're going to look at the fungus itself, its life, its path, basically how it gets from the outside world into a person. Okay, so remember that word dimorphic? This is where it gets really interesting. The fungus has this cool trick. It changes its shape based on temperature. We call it thermal dimorphism. So out in the environment where it's cooler, say 25 to 30 degrees Celsius, it's a mold. And it has these little structures that look like rosettes under the microscope. But when it gets inside a warm body, like ours, at 35 to 37 degrees, bam! It transforms into a yeast. And this yeast form? It has a look that is classic, super high yield, something you absolutely have to know for exams. You'll hear it described as cigar-shaped. Seriously, burn that into your brain. Cigar-shaped yeast. It's one of the biggest clues you'll get when you're looking at a tissue sample.
So, let's walk through the story of an infection. Step 1 is inoculation. A thorn pricks the skin, or a cat scratches you, and boom, the fungal spores are in. Step 2 is that temperature change we talked about. Your body heat triggers the fungus to convert from its mold form into that pathogenic cigar-shaped yeast. Then you get a primary lesion, a little papule or nodule right at that entry spot. And finally, from there, the yeast can hitch a ride on the lymphatic highways, traveling up your arm or leg and causing more trouble along the way.
And that spreading process leads us perfectly into our next section, the clinical presentation. So what does this actually look like when you see it on a patient?
When it comes to the skin, you're usually going to see one of two main patterns. The first, and by far the most common, is the lymphocutaneous form. This is your classic Rose Gardener's disease. You have that initial lesion where the fungus got in, and then you see this telltale chain of nodules marching up the arm or leg following the lymphatic drainage. The other form is called fixed cutaneous. It's much simpler. It's just a single, lonely lesion that stays put. No lymphatic spread, no chain of nodules. Now, it's usually on the skin, but it can get more serious. These are rarer forms, but you need to know about them. If you inhale the spores, you can get a pulmonary infection that can actually mimic tuberculosis. And for folks who are immunocompromised, think patients with AIDS, for example, the fungus can go systemic or disseminated. That means it spreads all over the body, getting into bones, joints, even the brain. These are the really severe, life-threatening versions of the disease.
Okay, so you see a patient. You see that classic chain of nodules, and you're thinking, this looks like sporotrichosis. How do you prove it? Well, that's where the lab comes in. Let's talk diagnosis.
Look, the clinical signs can be a huge giveaway, but to be 100% sure, you need the lab. And when it comes to diagnosis, just remember this. Culture is the gold standard, period. If you can get a sample from one of those lesions and grow the Sporothrix fungus in the lab, that's your definitive diagnosis. Game over.
So, what are you looking for in the lab?
Well, if you do a biopsy and stain the tissue, you're on the hunt for those famous cigar-shaped yeast cells. And with the culture, you're trying to prove that it's dimorphic. So you grow it at room temp, around 25 degrees Celsius, and you should see that mold with the rosette conidia. Then you crank up the heat to body temp, 37 degrees Celsius, and watch it transform into the yeast form. That confirms it.
Okay, another classic finding is something called an asteroid body. This is a really cool thing you can see under the microscope, also known as the Splendor-Hopeley phenomenon. What you see is a central yeast cell, and it's surrounded by this eosinophilic, starburst-like halo. It looks just like a tiny asteroid. Now, it's very suggestive of sporotrichosis, but it's not 100% specific to it. Other things can cause this too. So it's a great clue, but it's not a substitute for that gold standard culture.
All right, so you've confirmed the diagnosis. What's next? Let's talk about treatment and, maybe even more importantly, how we can prevent this from happening in the first place.
Okay, for treatment, your go-to drug, the first-line choice for the standard cutaneous and lymphatic forms is itraconazole. It's an oral antifungal that works really well, and people generally tolerate it pretty well. Now, there's an older, super cheap option called potassium iodide, or SSKI. It works, but it can come with more side effects. And then, for those really severe systemic cases, the ones that have spread everywhere, that's when you bring out the big guns, IV amphotericin B.
Prevention really just boils down to common sense. It's all about putting a barrier between you and the fungus. So if you're out in the garden, especially dealing with roses or anything thorny, wear your gloves, wear long sleeves. If you're around a cat that has some weird skin lesions, just be careful. And if you do get a little prick or a scratch, don't just ignore it. Clean it out with soap and water right away.
All right, we've gone through a ton of information. So to wrap things up, let's do a super quick review of the absolute must-know facts, the key exam pearls you need to take away from this.
Okay, here they are, your top 5. Number 1, the nickname, rose gardener's disease. Easy to remember. Number 2, the bug is Sporothrix Schenckii, and it's a dimorphic fungus. Number 3, the morphology. You have to know this. Cigar-shaped yeast at 37 degrees, and the mold with rosette conidia at 25 degrees. Number 4, the classic presentation is that lymphocutaneous form with the ascending chain of nodules. And number 5, treatment of choice, itraconazole. Got it?
So I'll just leave you with this final thought. Next time you're in the clinic and a patient comes in with a weird non-healing lesion on their arm that's been there for a while, and in their history they mention they'd love to spend time in their garden, what's going to pop into your head as a possible diagnosis? Yep, now you know.